Good afternoon. I'm Jana Martin, Chief Executive Officer of the American Insurance Trust, known to most of you simply as the Trust. We are delighted that you're able to join us virtually today for the next webinar in our virtual webinar series. The Trust is pleased to be able to offer this informative content free of charge to our policyholders. Today, the Trust is pleased to once again partner with Drs. Margot Adams-Larson and Sarah Smucker-Barnwell to present these telehealth community chats. In the interest of time, we've placed their bios on a slide for you. This credit can be combined with 5 other Trust CE credits to save up to 15% on your Trust-sponsored professional liability insurance policy. I hope everyone learns a lot over the next hour. Please join me in welcoming our esteemed presenters.
Thank you so much, Dr. Martin, and thank you so much to the Trust for having us today. Hi, Margot. How are you doing?
Hello. I'm doing awesome. How are you?
I am well. I'm excited to be here once again to engage in the telehealth community chat. This is a really delightful hour in which we talk about some of the practical, the ethical, and just the logistical concerns of this burgeoning field of telehealth, which many of us, whether we wish to or not, have joined in the context of the global pandemic. And I'm hoping folks are finding this to be a valuable area of practice. Well, we typically begin with our disclosures. As I always like to mention, both Margot and I engage in telehealth training outside of our work with the Trust. And so I mention that because I suppose we have a horse in the race of wanting telehealth to be wildly successful. But that is because we are both unabashed telehealth enthusiasts. So that should be in our conflict of interest too. We really like telehealth. Always, when you're giving a presentation on technology, something with your technology will go amiss. So I like to include that in the disclosure slides as well, so we can demonstrate some prescience when it happens.
And we go with the flow. So I'm super excited. This is one of the favorite parts of my week, and actually month, being able to chat with you, Sarah. And as you said, this is kind of a monthly check-in and just a time to be able to have some conversation with our telehealth community related to telepsychology and thinking through, the practice guidelines or clinical concerns, aspects of the regulatory environment, which right now is ever changing because there's a lot of different executive orders and telehealth related legal factors changing, and as always, thinking about the ethical considerations. So we try and mull all of that over as we're talking through a lot of the submitted questions that we've had, sometimes that we haven't gotten to in the past chats. Some have come in through telehealth community at trustinsurance.com. We love receiving emails and being able to get just a pulse on some of the questions and thoughts that you're having as you're navigating this new era of psychology. So with that, we have some resources that we've kind of talked about pretty consistently. And so there'll be a slide that will be available in the slide deck after the chat today. So if you're curious what the exact details are for those links, you'll be able to locate those on the slides at the end of the chat. Also, we just post the agenda of kind of the overarching topics that we'll be chatting about today. We're going to take live questions as well, and so we don't know what those are. They won't necessarily show up on the agenda, but just as a guide, some things that we plan to talk about. I'll leave the slide up for just a little bit, but I'll take it down so that you can see more of us and we can see more of each other as we're chatting through today. So, Sarah, I think one of the questions that had come in on our last chat was one that we wanted to spend a little bit more time digging into, a little bit more time exploring in terms of just our own knowledge and information. And that was related to telehealth when you're a prescribing psychologist. So I think there's a lot of different things that are important to consider here. And I'm just going to turn it over to you to tell us a little bit about some of the conversations you've been having.
Well, this was a great question submitted in our prior chat. And if I'm honest, I think stumped us a little bit. It was something that I don't think we had explicitly considered the intersectionality, or excuse me, we had not explicitly discussed in prior telehealth chats the intersectionality between prescription and interjurisdictional practice. Since the time that we met last time, I was telling you, Margot, before we began this chat, I consulted everybody I could find on the matter. I'd like to talk a little bit about some of the contributing factors. I think this is a very multifactorial question. And I will start off with the answer that I can give, because isn't it nice? You should give the answers you can give, the good news first. So I think the one area in which there was some consensus is if you are a psychologist, licensed, both as a psychologist and also with prescription privileges in your jurisdiction, and you have a client also in your jurisdiction, and you are traveling outside your jurisdiction. And by that, I mean, perhaps you're going on a trip or you're visiting someone, so forth and so on, a vacation, if we still have these. And your client back in your home jurisdiction requires something, in terms of prescription. That was a circumstance that most people could agree would be appropriate to prescribe. Technically, there's an interjurisdictional component because the psychologist has now left their home jurisdiction, but everybody pretty much agreed that the client is in the place where the home state or home jurisdiction, then that is appropriate. Beyond this, it gets a little more complicated, and I wanted to outline some of those factors that I was thinking through, and I know others were thinking through on this question. So, I think there is this minimum concept that, the prescriber would want to be licensed where the patient is located. So, if I had, let's say, I was licensed in one jurisdiction that offered prescription privileges, but I was trying to provide interjurisdictional care to another state that did not offer psychologists interjurisdictional privileges. Obviously, I could not prescribe to a state where those privileges were not offered. So I think the general gestalt, again, there was some consensus that even if we're talking about this, there's this question of if a client would be traveling to another state outside the home jurisdiction versus if that client is a resident of another jurisdiction. It's sort of an unknown, it's a bit of an unknown area. So, there's this question of, let's say your client goes on vacation and they needed a prescription while they were on their vacation. Technically, if you're not licensed to prescribe where they are, this is a riskier proposition. One of the themes that emerged as I consulted with others was this notion of networking with other prescribers, particularly if you are working interjurisdictionally and knowing prescribers in the areas where your clients are located. Some folks mentioned the concept of these temporary practice provisions that we're seeing. ASPPB does a very nice synopsis of some of the temporary legislation or, often gubernatorial orders that have emerged facilitating interjurisdictional practice. So, for example, some states have said, oh, well, psychologists can practice interjurisdictionally, for this period of time in the context of COVID. However, I have not seen in any of those circumstances, those permissions extend to prescription. So I want to be really clear that, no one seemed to think that, although we're now in a period that is a little bit more permissive regarding interjurisdictional psychological practice, that typically does not apply to prescription. So at the end of the day, that is clear as mud. I've outlined some of the various concerns, but I think at the end of the day, what I really took away from some of this consultation was we have to contact the boards. Contact the board where I am located, contact the board where the patient is located. Finally, I'll note that some medications, particularly controlled substances, have additional legislation, that regulate their prescription and particularly their prescription across borders. So I think this is an area of burgeoning practice. There are 5 states currently that offer psychologists privilege to prescribe. So it's not as widespread as other privileges. And oftentimes, Margot, as you inform me, that privilege may or may not be monitored by the Board of Psychology. So at the end of the day, I think my counsel would be, for all those circumstances outside the one where just you are traveling, but your patient's in the home jurisdiction, that we really do need to talk to both boards. We need to document, and really plan ahead. This is not something we want to be caught doing on the fly. because it just does seem to be a riskier and less well-defined area at the moment.
And Sarah, I would just kind of echo all of the information that you've shared, and being clear that the board that you need to ask may be multiple boards, because it may be a different board that oversees the privileges for that prescribing. And that may be true in your home jurisdiction, but it may also be true in the other jurisdictions. So there's just, it requires that forethought and thinking through and planning ahead.
That was a tough one. That was one, you know.
It was a good one though.
Not a satisfyingly clear answer, unless you're just going on vacation and we have a satisfyingly clear answer. But for most other circumstances, you know, really is going to be one that planfulness, consultation, documentation would be our counsel.
Awesome. You know, Sarah, we've had a whole other area that we've had a lot of questions about just thinking through telehealth patient care when the patient has suicidal ideation or suicidal history. And so I thought you'd be a great person to chat a bit more about kind of just some of the ins and outs. And, you know, again, some of these are what happens when a suicidal patient switches jurisdictions and lives somewhere else. Or maybe even just some basic risk management related to providing telehealth care for patients with, you know, not as clear-cut stability.
Sure. This is, again, you know, a really important question. And now I think we're seeing more mobility in our population in well, excuse me, I should say, in some ways less mobility, because again, we're not going on vacations as much. We're not going here and there. But I think we are, with the popularization of remote work, you know, with many people creating pods with families, we are seeing people move about the country in different patterns than we have historically. And so, you know, I think these questions of interjurisdictional practice become more salient. And then, of course, when we're thinking about our most vulnerable clients for whom there's emergent risk, this is especially relevant. So again, this is one of those areas where I think we are paid dividends by the early investment of research. So the more we well research this early and often, we will have a better outcome. So to me, this is a question of several themes related to risk management. One, you know, being thoughtful about the issue of interjurisdictional practice. Of course, if my client with emergent needs travels outside the jurisdiction, there will be potentially, you know, considerations there. I can't be practicing where I'm not licensed. But then additionally, there is this concept of ethical abandonment. You know, if I have a client who is an emergent need, you know, what do I do about this? To me, the best answer I can give for this matter is, you know, being thoughtful about this like much in advance. I think the more we do this in advance, the better off we are. So, you know, themes such as where is the client going? You know, is the jurisdiction where the client is going a place that actually does have one of these temporary orders that is more permissive regarding interjurisdictional practice? Could I be in a circumstance where I could request, you know, some sort of temporary privilege while this person transitions? I can share with you anecdotally, I've had several clients leave the area where I am, Washington, you know, and go to other states. In each of those circumstances, where the client I felt, you know, had emergent needs and I wanted to be helpful with their transition, I wrote to the board and they gave me a lovely form to fill out. And, you know, I defined how long I would be offering care, the circumstances under which I would be giving care. And in each of those circumstances, I was permitted permission. So the investment of some time contacting the board, documenting that content, I think was very valuable. So I think we want to contact the board where the client is located as soon as possible. And then, you know, ultimately, we want to do what is right. You know, so if our client calls us and they're in an emergency and they're out of state, you know, I doubt we're going to say prank call her and hang up the phone. You know, I think we're going to try to do what's right, try to respond to an emergent circumstance. But I think from the second we're aware of that situation, We are researching, we are helping to make the transition in care. And we don't want to loiter here. So if I have a client who is transitioning to a new jurisdiction, I've requested permission from the board. I'm typically very explicit that it is my intention to transition their care within X number of sessions. And I'm very transparent with the client also that I'm received permission from your board to practice temporarily interjurisdictionally. But at the end of the day, I'm not allowed to keep doing this. So we need to find you care local to you. Again, it's not quite the same as having just a clear-cut answer, but I think, again, we want to think about those risk management considerations when providing telehealth care, and the best risk management happens before the session. So, Margo, you were asking about sort of generally good practices. I think it comes down to planfulness, documentation, thoughtfulness, and we want to think about that client's clinical factors. What is their stability currently? What is their history of mood stability? Do they have a history of hospitalization? Do they have a history of suicidal behaviors? Do they have psychosocial stressors? I think we all have psychosocial stressors in 2020, but how is that, what is going on in their lives? Do we anticipate, this being a concern? And then we want emergency planning, that is thoughtful and, considering what resources are local to them. So again, this is always good care for telehealth. This gets a little more complicated when we're talking about the theme of interjurisdictional care. This relates also to this idea of if I had a client moving interjurisdictionally and I was helping them transition, I had permission from that board and from my board to do that. I would be helping them research meds providers too. They would need to be transitioning all of their care. Let's say I was someone who had prescription privilege. So we want to be comprehensive and thoughtful about getting that transition done well. What resources are available to them locally? Do they have someone in their life who can be a support person in case of emergency? Are they willing to sign a release of information so that person could help in case of an emergency? And at the end of the day, what is your willingness? What is your willingness to manage this really multifactorial process? It's stressful. I'll tell you, as I practice, I have certainly had circumstances where clients have had needs, after they have left my home jurisdiction. I'll tell you, my formula every time is I take the phone call. I'm not going to hang up the phone if someone's calling me and they have an emergent concern. But my very next step is to contact the board where they are located. I typically, I'm already, we're working on transitioning their care. If we have not already, hopefully I had already when they had moved, but in a few circumstances they had left the care that they had transitioned to. So once I have my permissions, I work with that person, and the explicit goal is to get them transitioned to care local to them.
I think these are, really poignant tips at this point. We've got a lot of students coming back to college, or sort of almost back to college, or they're back to college and now they're quarantining elsewhere. And I know this was a question kind of wrapped a lot into the idea of some of those changes right now just within the time of year for folks transitioning to school or back to school, and those moves and different jurisdictions being relevant to just the movement of the population, and or an automatic, like a student who you have been seeing who may now not be at college. And so, just a lot of that kind of reflects over the past couple of questions that you answered of it takes time to plan, be thoughtful, and have that kind of risk management mindset ahead of before you start seeing patients, so that you have a plan to follow as things transpire.
And I should note, I'm aware of colleagues who will say, well, for me, that transition is a transition to emergency care, and at that point, they're working with the social work staff of the emergency room, so when I say transition to care, optimally, my client is not in such distress that that's the necessary boundary. But if it is, I've had colleagues who talk about, well, no, we're pursuing an inpatient hospitalization. And from there, I'm working with their triage folks to help, with an appropriate release of information to help my client be placed locally.
Fantastic. I'm wondering if we've had questions come in that are kind of related. I know we kind of decided this time we'd take some parts out of just what we had prepared from our the emails that have come in. So I know you're monitoring that.
Well, let me read a few of them to you. They're very good ones.
All right.
So here is one. Our state psychology board recently advised us this. As psychologists become more rooted in the use of distance communications for service provision, those who opted to transition from in-person service to telephone and other unsecure communications to address the emergency need of clients should be transitioning to secure web-based communication platforms. What do you recommend for patients who want to remain with the abhorrent telephone sessions? I was surprised by it.
Great question.
Great question. I was very surprised by that because, you know, and Margot, I'm interested what you think. I am not aware of telephone as being regarded as poor security. I perceive, I would agree with the concept that the technology of telephony, you know, is not as well secured as a HIPAA compliant video conferencing platform designed for healthcare. I also want to acknowledge that any problem I've ever heard with telephone has had to do with use patterns, you know, people yelling loudly, being overheard, or, you know, they're not doing their session in a secured space. It has not had to do with the technology. But I'm curious, I was surprised to read that, you know, telephone sessions were being regarded as not secure.
Well, it is interesting because it does beg the question of what kind of telephone system are we talking about? You know, at this point, I think a lot of offices actually have a VoIP telephone system that isn't necessarily a landline, and that's really become the technology standard of, you know, telephones. And so I guess I remember when we first were doing our workshops on telepsychology, this was something we did, you know, bring up and chat about. And I think, interestingly, in that span of time, the world of technology has changed considerably in terms of that kind of sense of security of telephone calls. With all that said, I guess, if there's to be a recommendation for patients who want to remain with a telephone session, I would wonder if it's to remain with an audio session, or, you know, is the patient rather skeptical about the internet and, you know, what could be comfortable, and, you know, for the patient's comfort side of what they're comfortable managing with technology when it relates to the internet, because they may be, you know, like you said, the telephone itself may not be less secure necessarily in the communication patterns. It may be more about, you know, how they're using it, and that, you know, that could be solved by some education.
I do want to acknowledge that there are products out there that we can purchase that offer HIPAA compliant, secure voice over internet protocol. So there's a burgeoning market for that. I honestly don't know that many folks who use them, but it's something you can buy. You know, I had to reread that question twice, because initially what I thought they were saying was, you know, the state was saying, well, people might have started off using a platform, video conferencing platform that was not secure, like or you know, something, and now they should be really getting around to getting a product designed for healthcare. I mean, that being said, if that's the guidance you are receiving from your state, I would counsel you to do it. But I think for people who really wanted to shore up an audio only session, you could do one of several things. You could purchase one of these secure voice over internet protocol phone lines. You know, if your client was amenable to it, you could use just the audio function of Zoom. So many people just call into Zoom with a telephone. You don't have to enable the video. It is optional. So, you know, that would be one potential way to make sure that you're using a HIPAA compliant platform without, you know, they don't have to have a webcam, they don't have to engage the video, they can still just dial a phone number from their phone. But on your end, you're going to be setting up a video conferencing call. It's just that they would have a call-in number, you know, instead of calling your office.
Right. It certainly begs the question of how you would continue with some of the other best practice guidelines that we've suggested in terms of being able to verify it is that client. You know, often that's done through visual, or we've suggested holding up things to the camera so that, you know, you could see signatures or those kinds of things. So There's definitely, I think, some wisdom in this idea of making sure that there is a platform that is secure, that you can transmit information through. But if it means you're going to have, if it's a barrier to care, then it's an issue of contacting, I think, the licensing board, the psychology board, it said. So, maybe really having a better understanding of what their intent and meaning is behind what that advisory statement is. And if the advisory statement is an advisory statement, it may not be a legal platform. So, I mean, there is that also to consider too.
Shall we answer another one of these?
Let's go for it.
Do it. What place of service code is best to use if I am not on an insurance panel, but want to help clients to get insurance for a session? So I'm assuming a super bill for out-of-network reimbursement. And the good news is it's the same. It's the same whether you're out-of-network, in-network, billing insurance, not billing insurance. The same with a caveat. The technically correct place of, doesn't that sound dubious? But the correct place of service code is 02 for telehealth. So in the place of service spot on your CMS 1500 form or whatever online interface you're using to submit claims would be 02 for telehealth. Now, anecdotally, I will tell you that because so many insurers have had to quickly transition to reimbursing so many telehealth claims, I have heard anecdotes of, and actually I can tell you there's one in Seattle that does this, that is asking for something different. So there's a very popular insurer here in Seattle that has said, oh no, we want you to use place of service code 11, which is for just a regular outpatient office environment, which is frustrating. But I would encourage folks to ask the insurance, especially if it's one that you work a great deal with, and you are in network for insurance, I would ask, what it is they're looking for. But if you're looking for the technically correct answer, it's 02.
Sarah, I've got a follow-up question for you on kind of related to paperwork and insurance companies, and it actually came into us through the telehealth chat, and maybe I'll kind of segue it right in here if that's okay. One of our fans was wondering if you're doing 100% telehealth, so you don't really have a specific physical address where your practice is. We've addressed this question previously about can you use a PO box or whatever in terms of the physical address for mail, but I think in this case it really is, if you're trying to get mail from your clients, like whether it's a check or whether it's a consent form that they've signed, not telephonically or through telecommunications, what kind of address do we use for that? Does it need to be an office address, or can we use our home address? And what are the pros and cons and those considerations for either the insurance company or working with clients?
I saw that question too. I thought it was a great one. I think my perspective is that I am remiss to share my home address with clients. I mean, as a general matter, I think that's a widely held area of caution. I will acknowledge that many of us are working out of home offices, and to receive our mail at home might be the most practical. But I do think this is a circumstance where having a PO box or having, some sort of something where, if you're not going to your physical office, but you have a physical office, I'm still having my mail go to my office. It happens to be 4 blocks from my home, so I can go get it. I am remiss to do that. I have heard some colleagues say that they are willing to share it with the insurance company, but not clients, so that they can receive EOPs, to their home address and review those. I think that I understand what they are saying. My concern always is that insurance companies very typically will make referrals from their in-network panel, and they will share the address, that is on file. And so I would have concerns that the information that I'm communicating to insurance could then, through a game of telephone, be communicated to prospective clients. And so that I would not be keen on. I think that would be incautious. And I will tell you, I'm aware that some folks do this, and I think that this is going to be a personal risk management question. For me, I feel like it flirts too much with some boundary concerns. And then just from a safety concern, you know, I wouldn't recommend it, depending on the type of work you do.
Well, I know we've got other questions coming in. Do we want to transition a little to some of the other previous questions we've had? Does that
Sure, let's do
sound like
that.
a good
and
plan?
We'll
Okay.
circle back to some of the live ones.
All right.
So
I know one of the, go ahead.
I think we're going to say the same thing. A theme that came up a great deal last time, but has really historically been coming up, you know, is how to think about telehealth with children, adolescents, families, you know, some of these clinical circumstances that are just more complicated in the telehealth milieu.
This is, I think, a really awesome question, because as we're navigating, we all kind of shifted really fast, and now we're like, okay, we're trying to figure out how to make this all work, and we're getting to a point of I think both experience with telehealth for those that pivoted in March, but also our clients and patients are getting a little bit more savvy and kind of some tired, some maybe frustrated with this process of we're all trying to be the Brady Bunch screens, and or we're all trying to squish on one couch so the therapist can see us in the one screen they have. And there are a lot of challenges with family therapy in particular, where you know, if there's one location the family is all meeting, that trying to squish in the screen for us to have the view far enough so we can see everyone in the camera as we would in the office, versus, you know, being able to focus in and really seeing some detail and gathering behavioral observations that might be more helpful. And it is a lot more challenging to navigate a family on a video conference when they're all in the same space. And, you know, sometimes I think just being real transparent and passing the phone around, as is sometimes the case, you just get passed down the couch or around the table, and then be able to have some individual time, not necessarily session time, but just more up close, and being able to kind of have a little bit more connection in that way, and for some of your session time, and then maybe for part of it being able to see everybody. But again, it's almost like working double time, where we're being mindful of what we're doing clinically, but at the same time, we're also trying to choreograph and orchestrate. Okay, can you turn the camera a little bit so I can see, you know, Dad over here, and, you know, then the cat jumps on the keyboard, and then the phone is, you know, I've seen it all in the past few months. So, you know, I think having the realization that it's not the same as in person, and again, it's trying to plan ahead for how are we going to navigate this, because the scene is different. You know, when we've got little kids that we're trying to manage, or teenagers who've got, you know, their hood all covering their, I mean, we get the same stuff, right? It's all a matter of kind of thinking through how can we manage all of that while we're also, you know, still engaging in the service delivery and being able to see everything that's going on. I know a lot of questions have come in about, you know, do you let kids play or not play with the device that you're delivering the services on, and finding ways of thinking through and or plotting out a session that might be very different than how you thought about it in the office, where you can kind of entertain and keep them, you know, engaged in session at the same time you're talking to a parent. It just is not as easy and as possible to do that when it's, you know, one screen that the family is viewing. I think another whole side to this is when families or parents specifically reside in different jurisdictions, and that of course has always been an issue. You know, I remember many years ago Eric Harris presenting on this topic and suggesting that if a parent lives outside the jurisdiction you're licensed in, they either need to come to your jurisdiction or you need to know you could be, delivering services into that jurisdiction, meaning taking phone calls or calling the other parent, which is so terribly important when you're working with kids who have divorced parents or separated parents, or even parents in the military where, or, for other job reasons, the family isn't separated. They're just geographically not located in the same place. And I think that really has come to pass in COVID, where we're seeing, even just locally across state lines, that families may be disjointed because of quarantine and other reasons. So all of those same interjurisdictional questions and responses that we've had previously really come to play. You have to absolutely do your homework, and one provider situation is not the next provider situation. And so the magic, there's no kind of magic answer to it, can you do the service or not, but there is a recipe, which is simply contacting all the boards that you are under jurisdiction of. And I'll kind of reiterate, if you're a prescribing psychologist, then you need to contact all the relevant boards, which may be your psychology boards in your jurisdiction and the other, and it may be whether it's the medical board that issues the privilege for prescribing, or whether it's under a health department, wherever that prescribing privilege jurisdiction comes from, you need to be contacting that entity as well, and that may be in your state as well as the other state.
That's well said. I think you sort of mentioned something that was a theme that came up a great deal last time, and if it's okay, I'd circle back to, which was setting the environment, particularly that video environment, to capture, in that case, a lot of clinical complexity, and what are the things we can do to optimize for that?
I think it's a really awesome question, and it comes up to kind of, for me, two aspects. How many video screens of patients are coming into my feed, right? So parents could join on different devices and potentially be in the same room, or it could just be the whole family in one screen. And again, I think it's really important to think about the orchestration of that, and partly that's up for us as clinicians to guide. Here is my new office experience. It's virtual, and there are some of these things that I may be asking you to do that would seem kind of weird in the office, but in order for me to capture the behavioral observations and the subtle things that are so terribly helpful from a clinical standpoint, we're going to need to move the device farther back and figure out how we can still have some individual communications, et cetera. Does that answer kind of what you were getting at with the views?
Yep.
Awesome.
Well,
so I think we've had kind of one other question that came up with that video screen view that I thought was really intriguing, and that is the folks have noticed that we both have doors in our backgrounds, and I changed things up today. Like, I have a whole new, I have my real office background, but I still have a door.
it's to communicate the openness of experience.
Yeah. So again, the question that came in was, is it purposeful that we're actually showing the door, whether it's open or closed or whatever, in our background? And I will answer for myself. It's just, that was the location of where I could get the best light for a video camera, and also a clean kind of background for where I was in my previous environment. And this is where my desk is, so this is how it is. How about for you?
For me as well. It's funny, I did a class on telehealth where we had one room, three ways, where I was in this office, and this was one of the views. And then we had a view that was just terrible. It just had the light was in the back creating a halo, and there was messy things, and and then we had another view that was a little homier, where I'm in a room. This is my office, but there's also a small chest, and you could have a little homier view. I tend to choose this view, which does include a door, though the door isn't necessarily intentional because it's quite austere. So there's nothing really in my background. There's no personal photos, there's no political art. There's nothing that really discloses too much about me, clinically. And that's why I like that in a telehealth environment. I will share with you, though, when I did my one room, three ways, I got a lot of feedback that some folks really liked the warmer, angle on the camera, where there was a chair and there was, a little desk, and you could see more that I was like a human being, not just a woman sitting against a wall. So I appreciated that. Yes, I will say this, for me, I do like the lighting best here. And of late, my office has also become a home for wayward American Girl dolls from my child. So this is also a good angle for that.
Fantastic. Do you want to transition to some of the questions that are coming back in?
Yes, I'm observing the time and thinking a little bit about that. We have a great one, Margaret, I'm going to ask you. It's a good regulation one. So this is about SciPact, and I think also about ePassport. So would the SciPact telehealth interstate license still require the psychologist to physically be in the state of her license? I understand that the client would be in a SciPact state, but I would like clarification of the location of the therapist doing telehealth.
That is a really good stumper question. Because I will say we would need to go in and look at the exact language of what's been adopted in the compact. And I think that's a follow-up question that is easy for us to answer, but I don't know the answer right off the top of my head.
Let's include it next time. Sorry to do you like that. I'd say
no. I mean, this is, we don't know. We'll find out.
Yeah, my first blush, would be that if someone was participating in the ePassport program, offering telehealth interjurisdictionally and appropriately through that mechanism, through ASPPB, that they could be located in their home jurisdiction delivering, so that, that you would not, I think the concept is you would not have to travel to the client's jurisdiction to provide care to them, and you don't have to go get licensed in the client's jurisdiction beyond, holding this permission through the ePassport program. But we're going to go research it, and next time we'll come back with a meatier answer.
Well, for sure you can be in your jurisdiction. I think I maybe was understanding the question differently in what you were asking. I thought you were asking if we traveled to a different jurisdiction, could we still do telepractice? And that is not clear to me.
I did, yeah. I was not thinking of that. That I would need to look up. I would presume, I'm not going to presume, because you know what they say. That's not exactly the same.
That's a great question.
Okay, well, shall I ask us one more?
For sure.
Okay, I'll do a quick one because I'm cognizant of the time here. If you call 911 locally and say where the patient is located out of state, will that dispatcher call for help in that area if it's an emergency situation? It's a great question, and one that's changed over the years. It used to be standard of care in telehealth was to capture, this is very odd, the telephone, the local telephone number for emergency services in your client's area. And, in the early days of telehealth, I'd learned this, that very often 911 regionally will have a local number you can contact to reach emergency services. Over time, I think that has changed. That's no longer the recommendation. The recommendation is to just call 911 and to trust that those folks are pretty darn good, at triaging appropriately and getting resources to the right place. So the answer would be yes, to call 911, and that is the appropriate space. I'm looking at our time, and I'm thinking, let's circle back to one of those last few questions that emerged in our last meeting.
Yes, where do you want to circle back to?
Well, I think last time we received an inquiry regarding working with indigent populations without access to the internet and devices. I was saying, well, how do you approach this? And I thought it was a really great question. And this is where I really do think telephone shines. I did at one point in my career, I was working in the VA system, and because of some of the ways in which licensure works a little differently, we were doing a great deal of work interjurisdictionally to very remote communities in very rural Alaska and Idaho and other areas that were, large but sparsely populated in some regions. And as such, the clients did not have as ready access to care. And in those circumstances, telephone was a boon. Sometimes, the client wouldn't even necessarily have telephone access, so they wouldn't have service that way. And so sometimes they could tell you usually within 30, 40 minutes where you could drive to get telephone access. So in some instances, folks would drive a certain period of time, a prearranged period of appointment time, and have the session telephonically. I think that a lot of video conferencing programs now have integrated mobile. So, I'm just thinking of like the Simple Practice product, the Zoom product, the Doxy.me product, all have the capacity to be on a mobile device. So if that person has a mobile device, typically it can support a secure video conferencing platform. So the thing I'll note is that if they have a smartphone and they're able to do a telephone session, good chance is that they have the technology necessary to do a video session as well. They don't need to have a laptop, they don't need to have a desktop in order to support that. I think that the one thing I'll note that we used to do, which I would want to know what type of systems folks work in. As an independent practitioner, I don't have tons of funds, to buy equipment for people. When I was the director of a hospital service dedicated to telehealth, I did. And in those days, what we would do is we actually bought iPads. There were iPads with data plans, because I worked in a hospital system that was paying people what we call travel pay, where they actually were paid to travel to the hospital. It was actually a winning proposition for everyone. The hospital would pay out less travel pay, and it would cover the cost of an iPad easily within a session or two. And then additionally, the person didn't have to travel. So we would actually send them an iPad with a data plan. Now it was locked out. They couldn't play games and text their mom on it. But, and some of them did show up on eBay. I'm not going to lie to you. But conceptually, I thought it was a wonderful program that really helped people, get care access. And mostly folks were very into it, and they really seemed to enjoy receiving their care that way, and they appreciated it. So, if you worked in a system that had budget for medical devices, that's lovely. Most of us are in independent practice. That's not an option. In that case, telephone and smartphone enabled platforms.
I think that's one of the biggest challenges, especially now with COVID, because there are a lot of people that might have traveled to where they could get Wi-Fi, or traveled to where they could use an office phone even for, a medical conference. And we just don't have that ability for some folks, that the clinics aren't open, or the community center with the Wi-Fi isn't up and running. You can't go there. And so I think these are really big challenges that for some of our communities, they're really experiencing a really, a need for other kind of systemic intervention for some of these behavioral health connections, or to be able to access service.
Margo, I wanted to tell you, one of our very helpful folks who was watching went and looked it up about SciPact and ePassport.
Fantastic.
And they did clarify that you have to be in your home jurisdiction in order to use that ePassport, which makes a great deal of sense. So we'll come back to it. We'll circle back to it. But thank you, to the viewer who submitted that. I appreciate it. Well, do we have time for one more question?
One of the things I love about the community. I think we do. Should I touch on the question about revising documentation? And, this has come up a lot with informed consent, and we've chatted a lot about how COVID kind of pivoted us to now, we got to include a whole lot more information into our documentation, because we didn't do telepractice services before, and now we're doing it now. And what do we need to include? The trust has some amazing resources that is always great to review, to incorporate, to revise from. So it isn't just taking a template and crossing off, and putting your name in. It really is thinking through, what is your practice model, and how do things really work in your office? And The model documents that the trust has created for all of us serve as that resource, not as a template to just post and use, but really as a template to guide you developing your documentation. And I think related to that, we want to be thinking through routinely every 6 months, or when you sign a new contract with an insurance carrier as a provider, or when you're signing your lease again or for your office, or you're getting a new healthcare platform system. These are all great times. To me, they're open opportunities to really go back through and revise and review and look at your policies. With HIPAA overarching rules and guidelines, we should be doing this at least yearly to make sure we're up to speed on what the HIPAA requirements are and how those laws may change, which of course we don't want to think about. It's a big elephant, but they do change from time to time, and we need to be informed about that and make sure that what we put in place a year ago is still relevant. And we've seen what we put in place a year ago, actually what we put in place when we pivoted to telepractice in March is now going to need to be updated, bless you, to really consider these ideas of, are we going back to practice or not? Who are we going to see? Who are we not going to see? Are we even going to open the doors? What are the requirements if we open the doors? What are we going to do? What do we need from a public health standpoint to manage having an open door? And what are the policies that our office needs to adopt for that? And all of that needs to be reviewed and kind of infused into what your practice documentation is. So I would just say it's always good practice every 6 months to be reviewing not just your practice documents for your office, including the informed consent, but also reviewing your state laws, because those change, and those you want to keep up with so that if there's any practice requirements you need to be paying attention to and infusing into your documentation as well.
And this is a great area where I often find myself consulting various sources, but consulting trust risk management services, because sometimes I read through something and I'm not an attorney, and I'm just like, I want some additional consultation on that, consulting my board, and it's good to know a local healthcare attorney. It's good to know someone locally who can answer questions of this nature, because there are some moments that I will review a statute and, I think that's unfair to put on me because I didn't go to law school. So I know we're getting right up to about the time, Margot. Shall we start doing some of our winding down here and these resources?
I think so. I want to say first off, it's always fun to chat with you, and I'm really enjoying the questions that are coming into our chats, the questions that are coming into our emails. It's really building a community, and I feel like that's a really important aspect to make sure that you're networking and communicating with colleagues on these topics as we're navigating it.